So good morning, afternoon or evening from wherever you're joining us. On behalf of the co-hosts of this event, the Norwegian Ministry of Foreign Affairs, the World Health Organization and the NCD Alliance, welcome to today's virtual event entitled NCDs and COVID-19, Learning Lessons Building Back for the Future. My name's Katie Dane, I'm the CEO of the NCD Alliance, and I'll be steering you through the opening of this event. And we're really delighted to see so many people having joined us. I can see 214 people so far, and that number seems to be rising by the minute, no doubt from all corners of the world and from many different time zones. Before we hear some words of welcome from leadership of the three co-host organisations, let me just get a few bits of online event housekeeping out of the way. Many of these things you'll be very familiar with already. Firstly, in case you're having any issues with following us on Zoom, we're also broadcasting this event on NCD Alliance's Facebook page, so you can also follow us there. Secondly, we really encourage you all to engage in the conversation today. And you can do that by commenting in the chat box on Zoom and also sharing your views on social media, tagging at NCD Alliance and using the hashtags #ActOnNCDs and Build Back Better. We'll be posting the Twitter handles of the speakers in the chat box as well, and you can find their profiles on the event page of our NCD Alliance website. Thirdly, this event is being recorded. And a recording will be made available to all a couple of hours afterwards, so you can listen back whenever. And finally, today's event is very much meant to be a conversation starter to inspire us and to challenge us. So all contributions today will be used by the NCD Alliance team, and I'm sure the other co-host organisations, and I hope many around the phone as well, to inform our work going forward on this topic. So in a few moments, I'll hand over to our moderator, but first, some words of welcome from the co-hosts of today to set the scene and to really frame the conversation. So let me start by passing over to NCD Alliance President Todd Harper, who is based in Australia, so far too late to be joining. So we have a video message from Todd to get things moving.
Welcome, Your Excellencies, Minister Ulstein, Dr. Tedros, ladies and gentlemen and colleagues. As President of the NCD Alliance and on behalf of our other co-hosts, the Norwegian Ministry of Foreign Affairs and World Health Organization, we're delighted to welcome you all to today's online event. Wherever you are in the world, we are all living through unprecedented challenges. The coronavirus pandemic is not only a threat to our health, but it has also crystallised pre-existing fault lines in our societies. Inequalities and injustices that we've lived with for far too long are ever more apparent. We might look back on 2020, the crises and social upheaval, as an opportunity that we had to affirm that we won't return to the old normal, but rather we affirm the values that must underpin our health systems and societies for the future. The COVID-19 pandemic shows that people living with non-communicable diseases are at higher risk of becoming severely ill or dying from the virus. We already know that the vast majority of people who have lost their lives to COVID-19 had what the media sometimes describe as underlying conditions, and in particular NCDs. There are real people, families, communities and stories behind every one of these numbers. Today, nearly 1/4 of the global population, 1.7 billion people, are living with one or more NCDs, which put them at higher risk from the virus. The collision of NCDs and COVID-19 threatens to leave a legacy of long-lasting impacts in three ways that I'd like to describe today. Firstly, as a result directly of the virus itself. Secondly, as an indirect result of disrupted or delayed care, screening, diagnosis and treatment. And thirdly, as a result of the policy responses, lockdowns, travel restrictions, distancing, increasing exposure to NCDs and mental health risk factors. The pandemic starkly exposes the link between NCDs, communicable diseases and health emergencies, and shines a light on uncomfortable truths. One being the importance of public spending on health, prevention and essential public health services, and the importance of this for all of our countries. As a result, now many countries are finding themselves unprepared to face COVID-19 because of underinvestment in these critical areas. And people living with NCDs are often the most affected, but the impact will eventually touch everyone by destabilising our health systems and our economies. We've seen the epidemic preparedness rankings like the Global Health Survey Index are turned upside down by COVID-19, and that will come as no surprise to many of us. Causes of poor health, including broken food systems, poverty, inequality, have catastrophic consequences for our health and the health of societies. Unhealthy political decision-making predates the pandemic response. It goes back not just months, but years. But COVID-19 provides an opportunity for our world leaders to chart a new direction that prioritises the health of our people and the health of our economies. We know this can be done. It can be done by action on NCDs and risk factors that cause much harm: tobacco, alcohol, unhealthy food, air pollution, physical activity have made us all more vulnerable and our nations less secure. 2020 will be the year we truly understand that emergency preparedness depends on strong health systems, a resilient, qualified, well-resourced workforce and healthy populations. Indeed, our future health security and economic security depends on finally taking action on NCDs, as well as learning the lessons for infection control. Before I hand over, one of the key lessons that is being learnt during the COVID-19 period, as with so many other global health crises, is the critical role that civil society can play in the response. Whether delivering services on the front line, raising awareness, supporting communities, providing a voice for affected communities and a voice for the most vulnerable, and gathering and presenting data and real-world evidence to inform policy decisions. To support these efforts and to protect and safeguard the sustainability of NCD civil society movement around the world, NCDA is delighted to be launching today our new Civil Society Solidarity Fund on NCDs and COVID-19. I'm really thrilled and excited by this new initiative. It is the first of its kind, a solidarity fund that is dedicated to supporting civil society in their moment of need and particularly in their response to COVID-19. With a total fund of $300,000, it will competitively award grants to 20 national and regional NCD alliances from across all regions. These grants will strengthen their organisational resilience and sustainability, support them in addressing the challenges and implications of COVID-19 as coalitions, and in advocating for public health, stronger health systems, and meeting the needs of people living with NCDs. We would particularly like to thank our wonderful NCD Alliance supporters who have made this possible. Thanks to generous financial contributions, the Leona M. and Harry B. Helmsley Charitable Trust, Access Accelerated, Takeda, AstraZeneca and Upjohn Pfizer. A strong civil society movement is essential to build back better and shape the legacy of this pandemic. The new Solidarity Fund will ensure NCD advocates can continue their much needed work around the world. I look forward to the discussion and hear what we can do all together to build back better for the 1.7 billion people living with NCDs at risk today and for today's youth and future generations. We know very well that the majority of NCDs can be prevented or treated with smart policy measures and sound investment in universal health coverage. Inaction on NCDs is another injustice and one that I know collectively we refuse to accept. I thank you all for joining us today and wish you inspiring and productive discussions. Thank you very much.
Thanks very much, Todd, for setting the scene there and really highlighting the intersections of NCDs and COVID and obviously the critical role that civil society is playing with the announcement of the Solidarity Fund. Now we're delighted to have a video message from WHO Director General, Dr. Tedros, who will be providing his reflections on today's topic.
Excellencies, colleagues, and friends, it's an honor to welcome you today to the webinar on the deadly interplay between non-communicable diseases and COVID-19. I would like to thank my friends, Minister Ulstein, Norway's Minister of International Development, and Todd Harper, President of the NCD Alliance, for co-hosting this important event. COVID-19 has a major impact on populations with a large percentage of people living with non-communicable diseases. People living with NCDs are both more vulnerable to COVID-19, even as the pandemic has made it more difficult to access for their underlying condition. Our health systems struggle to cope with an emergency while also responding effectively and equitably to the healthcare needs of people living with NCDs. We need a paradigm shift to include the prevention, screening, early diagnosis, and appropriate treatment of NCDs as a part of primary health care for universal health coverage. First, we should have the voices of people living with NCDs at the table when making decisions that directly impact them. Second, existing global financing instruments must be extended to low-income countries that request support for NCDs. Third is to have constructive dialogues and partnerships with the private sector. We cannot go back to the same health systems model, which has failed the majority of people living with NCDs. We need to build back better. I thank you.
Thank you, Dr. Tedros, and thanks to you and the whole WHO team for your steadfast efforts to support governments in taking on COVID-19. Particularly really appreciate the emphasis on ensuring that the focus is on those most affected by the pandemic, particularly people living with NCDs, and no doubt that will be picked up during the panel discussion that will be starting shortly. Now I'm honoured to introduce a video message from our third co-host, the Norwegian Ministry of Foreign Affairs, and we have the Minister of International Development, Dag Inge Ulstein.
Excellencies, ladies and gentlemen, dear friends, the NCD crisis is a silent crisis that has been going on for more than a decade. Worldwide, 41 million people die every year due to the slow silent killers: respiratory diseases, cancer, cardiovascular disease, diabetes, mental illness, and other non-communicable diseases. More than 800,000 people commit suicide. The death numbers are rising year by year. Also, younger people are dying. NCDs cause more than 50 million premature deaths annually. A large majority of these premature deaths occur in low and middle income countries, as much as 86% actually. And now, people who are living with NCDs die from COVID-19 because people living with NCDs have increased risk of becoming severely ill or die from COVID-19. In Italy, 68% of the people who died from COVID-19 had high blood pressure, and 31% had diabetes. The WHO calls this comorbidity between NCDs and COVID-19 a deadly interplay. One explanation is the long-time global underinvestment in NCDs prevention and control. Today we will talk about how we can tackle this dual crisis, NCDs and COVID-19. From WHO's assessments of impacts of the COVID-19 response, we see that NCD prevention and treatment have been disrupted in many countries. Fewer cases of NCDs are discovered because of the lockdowns. People living with NCDs do not get the treatment their survival depends on. Essential rehabilitation services after heart surgery and strokes are disrupted. Therefore, countries need to include prevention, detection, treatment and rehabilitation of NCDs in their COVID-19 response plans. We will also talk about how we can build back better. The past months we have experienced what governments, health personnel and people all over the world can do when facing a health crisis. It has been extraordinary, overwhelming and absolutely impressive. We need to use this spirit, this strong will of people and governments of winning the battle, of ensuring the survival of neighbors and fellow global citizens, because premature deaths from NCDs are avoidable, the same way as COVID-19 deaths are avoidable. We know how to prevent them. This would also have economic benefits, since NCDs have huge economic consequences for the individuals and their family. I am so pleased to co-host this event together with the World Health Organization and the NCD Alliance. They were also important partners when we launched the Norwegian NCD strategy in November last year. Better health, better lives, combating NCDs in the context of Norwegian development policy. WHO is our main partner in the following up of the strategy. NCD Alliance is also an important partner, since the efforts of civil society are invaluable if we are to win the NCD battle. Norway was the first donor country with a strategy focusing on NCD action in developing countries. I hope other donor countries will follow our example. There is a huge need for funding. Despite the enormous death burden in low and middle income countries, NCD's efforts only receive between 1% and 2% of all global health-related development aid. We have started working on the implementation of the strategy. The work was put on hold because of the COVID-19 pandemic. Now we see that the action points that were included in the strategy are important also in the battle against COVID-19. We need to strengthen health systems in low-income countries. We need to prevent and reduce risk through multisectoral measures. And we need to increase the access to health data and health information. The WHO has found that both smoking and air pollution, two of the main NCD risk factors, are also important COVID-19 risk factors. People who smoke and people exposed to high levels of air pollution have higher risk of dying from COVID-19. This shows that the action points in our NCD strategy will be an important part of the Build Back Better strategy, and they will be important in order to fulfill the Sustainable Development Goals. Improving the health of the world's poor is not only a main goal in itself, it is also a major pathway to eradicating poverty. The time for action is now, because in only 10 years we are supposed to have reached all the SDGs. I wish us all good luck with the battle against NCDs and COVID-19. Thank you.
Thank you, Minister, and to the Norwegian Ministry of Foreign Affairs for your support today, and also for walking the talk when it really comes to investing in the NCD response around the world. As was stated, the first donor to have a dedicated NCD strategy as a development priority. And we very much share your hope that other donors will be following in your footsteps. With that, after the video messages from our co-hosts, I'm delighted to hand over to our moderator for today's event. Our moderator really needs no introduction. Ilona Kickbush is a global health reformer and founding director and chair of the Global Health Centre at the Graduate Institute of International and Development Studies in Geneva, as well as having held previous positions at WHO and Yale University. Ilona is a UHC champion, a very good friend to the NCD community, as well as being an expert in health security, holding many different roles with WHO in response to Ebola, the international health regulations, as well as being a member of the Global Preparedness Monitoring Board, GPMB. So we really couldn't think of anyone more suitable to be moderating this discussion on the lessons learned from NCDs in COVID and what that means for health security, for the emergency response and humanitarian responses going forward. So with that, let me pass over to Ilona, who will be steering us through the rest of the agenda.
Thank you very much, Katie, and I'm delighted to be here and have been asked to moderate this really critical discussion. We heard from Katie that this is the start of a process, of a very, very important process, and I've been asked to encourage you, all of those out there, a big welcome. I've been asked to encourage you to really use the chat function, to give ideas, to give proposals that the partners of this event can use as they try to move forward in addressing the interface between COVID-19 and the NCDs. Like some others on this panel and in this debate, I was a member of the NCD Commission that completed its work recently, and this is one development that we had not anticipated in our work, but definitely the many different points that have just been raised by the speakers that we've just listened to were raised again and again and again. The lack of investment, the lack of political will, the need to address the commercial determinants of health, the need to move out of silos to invest in health systems. So we're at a point where possibly for very tragic reasons with COVID-19, we might be heard. And we can show that this abstract element that is so frequently called preconditions or underlying conditions is really something very serious, something we could have avoided if we had invested better, and therefore also have addressed many, many of the inequities we now need to deal with. Some of the speakers already mentioned the Sustainable Development Goals, and it is truly, truly worrying that we are finding already before COVID-19 that we were not on track with the health goals. And of course, in many cases, we have again been pushed backwards through COVID-19. That means we need that extra amount of work to move forward. That also means, and I want to say this as the moderator because I feel very strongly about it, in this geopolitical situation, in this situation of very, very divided debates where all health issues are becoming increasingly politicized, that we do need to support WHO and its work, that we do need to support multilateralism, and we need to approach health in a new way of solidarity, that we really work together, because not only do viruses not know any borders, but also many of the other things we deal with do not have borders, require cooperation. And the DG on another occasion at the World Health Assembly has spoken about these many determinants, the commercial, the environmental, the political determinants that we definitely need to take into account. Therefore, I think it's also appropriate to start our discussions with another message, a message from what the organizers have called a government champion. We have with us Dr. Hugo Lopez-Gatell, who is Undersecretary of Prevention and Health Promotion at the Government of Mexico, who has played a very important role also as Director General of Epidemiology, and is a focal point, or has been a focal point, of the international health regulations. Already with him, as with other panel members, I'm not going to share with you every single fantastic thing they have done. You can read that up on the website, or if you search for them in a broader way. So it's my great pleasure to ask the organizers to share with us the video message from the Undersecretary of State from Mexico that has moved ahead so rapidly in relation, for example, to the sugar tax, but is facing tremendous challenges in relation to COVID-19. Please.
Hello, this is Hugo Lopez-Gatell, Undersecretary of Public Health in Mexico's government. I'd like to thank the NCD Alliance for its commitment and dedicated work to address the challenge of non-communicable diseases around the world. As you all know, Mexico has one of the biggest burdens of non-communicable diseases that has impacted not only the well-being of the Mexican population, but has even reduced life expectancy in our country. Therefore, it is important to continue finding potential solutions from the perspective of governments, society, and all sectors that can contribute to changing our lifestyle, changing our diets, changing the opportunity of having a food production system that becomes safer, healthier, just, sustainable, and competitive in terms of its economic capacity. I also thank Eric Ochoa and Coalición Saludable for its dedicated work in Mexico for promoting the development of policies that are based on science, on evidence, and that consider the opportunity of a wide social participation of groups that have independence from other interests that commonly have interfered with the progress of these healthy policies. Thank you very much.
Thank you very much to Dr. Hugo Lopez-Gatell Ramirez from Mexico giving us this message. It's been one of the things that has really been highlighted over the last months, how important food and food security are in the context of the COVID-19 crises. He has highlighted that again. And of course, he has highlighted the incredible importance of social participation. We've heard that from so many speakers, the role of civil society, the voice of those living with chronic diseases is an absolute must as we move this agenda forward. Now, the NCD Alliance wouldn't be the NCD Alliance if it weren't encouraging you to be healthy even during this video conference. So I have been asked to encourage you before we start with our panel, and I'm going to ask all the panelists to click on their video so you can see them all. While they do that, to get organized just like in a real-life conference as they walk on stage, I'm asking you to perhaps stand up or wherever you sit to, do a bit of exercise and move. And then we can really start and enter into the discussion that we will now have. While you are exercising, let me tell you how we will approach this. We have about an hour for this panel, which is a fantastic amount of time. So we can really discuss some issues seriously. We will have 3 rounds of the panel where I will be asking the panel members questions. They will make reference, of course, particularly in the second round, also to some of the comments and answers from their co-panelists. And at the end, we will have a final short round where I will ask the panelists, what is the most important takeaway in their view from this discussion and for the action of the NCD Alliance together with its many partners. As I've already said, I'm not going to do long introductions of the speakers. You can easily find out more about them. They're all extraordinary people, believe me, and their experience will reflect itself in their commentary. As is appropriate, we're going to start with the voice of an advocate living with a chronic disease, Ms. Nupur Lalvani, who is a youth advocate. She is with the Healthy India Alliance and the Blue Circle Diabetes Foundation and has been living with diabetes for 25 years now, and definitely has a strong experience in how you organize the civil society voice, how you get to be heard, and how you move an agenda forward. So I would like to ask Nupur, as a person with this experience over so many years, what challenges have you faced during the COVID-19 pandemic? What changed? And do your advocacy messages change through this? Does your life change through this? What has been happening, Nupur? Can you share that with us, please?
Sure. It's an honor to be here. Thank you, Ilona. Well, I am aware of my position of relative privilege in relation to a lot of other disadvantaged people living with NCDs. I faced a temporary roadblock as well in accessing my continuous glucose monitors, medical devices that I use for type 1 diabetes. My family was extremely anxious and worried about my well-being. So this was about me as a person living with NCDs. But what I felt is a reflection of the larger community as well. Our community-powered helpline, which we call the Blue Circle Buddy Project, is a diabetes and mental health helpline. And it came about because we received a call from one of our community members, a person living with diabetes, and she had a panic attack in relation with COVID. So, in the midst of this whole lockdown, our organization, we liaised with the local city authorities in our local areas to ensure that medicines and medical devices reach our community members, despite there being a strict lockdown in the country. And not only did we create a delivery system, we also got in touch with a local pharma company to get discounted rates for people living with diabetes. I mean, there might be COVID, but people still have bills to pay and medicines to have. So these are some of the things that we did as a community and that I experienced as a person living with NCDs.
Thank you, Nupur. And, around COVID-19, we're, of course, having this big discussion. How do we get access to medicines, to diagnostics, to vaccines, while at the same time, the kind of enormous access problems that you have indicated start to emerge. And frequently then there are difficulties for people with other diseases, and particularly chronic diseases, to have access to their regular treatments, to doctor's visits, and everything that you described. And that, of course, also has these larger components of supply chains that get disrupted both nationally and internationally that are very, very worrisome to us all. And again, it shows straight away that there are big challenges in such a borderless world. We'll come back to some of these issues in the second round, Nupur. I'm moving on now to Sir George Allain, that of course nearly everyone in this discussion will know well, who is the Director Emeritus at the Pan American Health Organization and was one of the strongest voices to actually get NCDs on the global agenda. I don't think we can thank him enough for that. But he has long argued that NCDs can be seen as a health security threat in themselves, not just in terms of the interface that we are discussing now. But Sir George, or I'm privileged to call you George, what is it, if you reflect on this matter now, that what do we need to learn about these interfaces between COVID-19, between NCDs? Is all this together a new security challenge? Is that the word we should be using? Or how should we be approaching this paradigm shift that I think the Director General of WHO called it?
Thank you very much, Ilona. You and I go back a long way in our various voyages in public health, so it's so good to see you and have you as moderator. But first of all, let me re-emphasize the point you make, that we should never lose sight of the security focus in this area. We have argued that to the extent that health security is a component of human security, and NCDs impact negatively on health security, you cannot delink NCDs from human security. So we postulate NCDs is an important aspect of both health security and ergo human security. Now, it is one of the things that has amazed me during the recent months is that there is much angst about preparedness, lack of preparedness. That's why we are here in this situation as far as COVID is concerned. We agonize over the lack of the plans, the policies, the resources that all are an intimate part of preparedness. And what has worried me is that we need to make the connection that there's no real intrinsic difference between the preparedness for COVID and the preparedness for NCDs. No real intrinsic difference. And I like the point that Todd made about the things that are necessary to deal with COVID. If we look at what are the major ingredients of the main emergency preparedness plans that have been put in place for the countries, what do we see? We see the same emphasis on surveillance, the same emphasis on community participation and involvement of civil society. We see the same emphasis on health systems. We see the same emphasis on the essential public health functions, that public health should be able to discharge these functions. We see the same emphasis on communication. And what I think is critical for us to take up, one of the things critical to take out of this COVID crisis, that we should be applying the same tools to deal with NCDs as we are applying the tools now to deal with the emergency preparedness for COVID. One analogy I often use is that in the acute phases of a pandemic, there's the panic, there's the hysteria, and then there's neglect. What I worry about is that we do not have the same neglect after the pandemic, and we continue to emphasize that we do not leave to rust the tools that we developed for COVID. We do not leave them to rust. We must utilize them as best we can for dealing with the chronic diseases pandemic. And we should not make too fine a distinction after COVID between a chronic pandemic of NCDs and the acute pandemic of COVID. In fact, if one looks in terms of what damage they cause for development, I like the minister from Norway emphasized at this point. If one looks in terms of development, NCDs is as major a cause for disruption of development as has been COVID, and over a longer period of time. So my essential takeaway, Ilona, from this is preparedness. Of course, we should emphasize and try to stimulate that there be preparedness for pandemics, because there will be another pandemic. Inevitably, there will be another pandemic. We must prepare for another pandemic. And in fact, preparedness for the other pandemic will be facilitated if we maintain the tools that are necessary in use for the treatment of the chronic non-communicable diseases. We must not leave this juncture to fester.
Thank you very much, George. And what you've been saying also reflects itself in what we have found in many countries now, that they have actually rediscovered public health and the public health functions. And many of these functions, as you rightly say, apply to any kind of disease within the large disease spectrum. I'm also reminded of the 5 action areas of the Ottawa Charter, which initially people thought applied only to NCDs, and then learned, no, they also apply to Ebola. And we're seeing this back and forth learning that is absolutely critical for the integration of building a strong health system that includes a strong public health system. I think this is a good message to move to the country level. And we have with us Ms. Sandhya Singh, who is the Director of Non-Communicable Diseases at the National Department of Health in South Africa. And Sandhya, how has it been in South Africa? How has the public health system been able to respond? How has that interface been between COVID and NCDs in relation also to some of the things George highlighted? What's your experience at this stage? Because we're in the middle of it, basically. What's your experience at this stage with the response?
Good afternoon and greetings from South Africa. Today marks 109th day of lockdown in South Africa. And in South Africa, similar to other low and middle income countries, COVID-19 continues to reveal deep inequalities, impacting on the protection of the rights, including access to health, socioeconomic development and justice of the majority of people in South Africa. And we expect that this impact of the inequalities will be seen for many years to come. Millions of our people have lost their jobs, have had reduced income, face poverty and a threat to their food security, and fear of the unknown, which has been created by anxiety, stress, and stigma. And most devastatingly has been the increase on gender-based violence during the lockdown period. His Excellency, President Cyril Ramaphosa, commenced his address to the nation at 8 p.m. last night. And he started by saying, "This evening, as I stand before you, our nation is confronted by the gravest crisis in the history of our democracy." And what is this crisis? And allow me to please share with you some of the statistics that led to the integration of NCDs into the agenda. Cumulatively, we have, as of the 12th of July, which was yesterday, our cumulative total was 276,242 across 9 provinces, and 35.6% of cases are in the Gauteng province where I reside. Our deaths are presently sitting at 4,079, and case fatality rate is 1.5%. And the highest death rate comes from the beautiful province of the Western Cape. Our recoveries at the moment are 134,874, which estimates 48.8%. And the President's plea was in relation to the fact that we are now sitting at 12,000 new cases a day, which estimates to approximately 500 an hour. Most significant trend over the course of the pandemic relates to the intersection with NCDs. And where does the emergency, where does this emerge from? Firstly, our burden of disease in South Africa. NCDs feature among the top 10 causes of death, according to Statistics South Africa, We have the highest proportion of population aging in sub-Saharan Africa. We have very high burden of risk factors and diseases of lifestyle, and obesity has raised its ugly head here. We've already had existing association with HIV, TB, resulting in increased rates of multimorbidities. So adopting vertical programs to disease management is no longer appropriate. But most importantly, we've had a lesser development of health systems in relation to the HIV and AIDS pandemic. So what has this helped us? We are very fortunate in that we've been able to accumulate in a very relatively short period of time significant data on NCDs during hospitalization and mortality. And please allow me to share some of these figures with you. A DATCOV is an NICD Sentinel hospital surveillance system, which we agree at the moment has limitations because it is not all inclusive of all public health services. But as of the 3rd of May, and this is very relevant to us because we have such real-time data, there were 4,718 COVID-19 admissions reported at 218 facilities, both public and private. And of the 3,737 with data on comorbidities, 1,127, which is 30%, had one comorbidity, and 1,295, which is 35%, had two or more comorbidities. And most common was hypertension, which was 56%, and diabetes, which was 48%. And of the 4,718, 608, which is 13%, died. And based on a multivariate analysis associated within hospital mortality, where older persons, male sex, hypertension and diabetes, chronic renal failure, and malignancy. This is a dynamic system allowing us to amend data sets on a regular basis. And we're very pleased now to report that we will be looking also at obesity. However, I would like to also share with you some data.
Sandhya, we're having a bit of a time problem. I'm sorry.
Okay. So I think in terms of data, but what has this data informed? This data has informed the need for multisectoral intra-programmed a response to COVID within the country. And what has happened since is we've now been allowed to inform protocols of other government departments, including the Department of Public Service and Administration, social development on managing cases at residential facilities, standard operating procedures with Department of Basic Education. But within the health sector, we've also had very clear guidelines, including...
Can we keep those for the second question, Sandhya, what lessons you've learned?
Okay.
As we move forward, I really have to make sure that the other speakers...
I apologize. We are having a very rich
You're doing
experience.
so much, it's so fascinating, and we could all listen forever, but I have this tough job to sort of stick to a little bit of equity.
I think just in conclusion is that the evidence has guided the expansion of the response and to ensure that NCDs is fully reflected. And just for evidence further, I sit on the National IMT, which is extremely satisfying.
Thank you very much, Sandhya, and we'll hear a bit more about these lessons and the new developments, and also this extraordinary political commitment in South Africa that we are experiencing also from your president. So we will come back in the second and third round. And I'd like to move on to Dr. Shannon Haider, who is Deputy Executive Director at UNAIDS. We've, of course, also heard that in terms of these preconditions, obviously, HIV/AIDS is also one of those preconditions, and in many countries, that is also an issue that needs to be taken up. We've just heard from Sandhya how important it is to break up disease silos. And I'm just wondering, from this long-standing experience of HIV/AIDS, you know, some people are also saying we will have to live with COVID just as we have had to learn to live with HIV/AIDS. Can you share some of your thinking and experiences with us? What can take us forward? Please, Shannon.
Sure. First, let me start by thanking the organizers. UNAIDS is really happy to be here with everybody today and to say congratulations on the Solidarity Fund. That is the best news I've heard all day, so very exciting. You know, I do think that this is a next moment for breaking apart some of these silos and seeing how we link things up better now and going forward. In part, COVID has made visible some of these connections that aren't always visible. You know, we've seen that infrastructure, human resources for health, information systems, laboratory systems that were quote unquote built for a vertical disease like HIV or TB are absolutely being leveraged, expanded on, and repurposed during COVID. So it sort of suggests, and it makes it more visible, these were never purely vertical investments. These were investments in a capacity to serve people. Second, and I think we've heard today throughout the speakers in terms of visibility, undeniable the importance of multi-sectorality, something we've known in the HIV response since the beginning, and it's coming out in COVID, and we know it matters for NCDs. So yes, attending to the health issues, but also attending to human rights and food security and violence and safety. So I think we've activated a certain amount of attention on these overlaps and connections. And now it's, you know, the question is how, as we move forward, can we continue to build on these so that we do build back better? And I think how we think about it a little bit has been the what, the how, and the who. So what gets connected, what gets integrated? And our experience has really shown it's not a one size fits all. What services you sort of connect, really you have to listen to the community on what makes sense to those people. There's a study that was called Project Search that was looking at how do you get universal testing and treatment for HIV in a community so that you can get 100% of people who are HIV positive to know they're positive and get into treatment. Well, one of the strategies they used is they started to build in multi-disease screening. So screening, yes, for HIV, but also for high blood pressure, also for eyesight. And they found that that was a really great way to start to reach men who were a lot more concerned about their high blood pressure than necessarily their HIV. They also found it wasn't really what reached younger men. You know, men 18 to 24 didn't really care about high blood pressure and prostate screening. So you had to package it with other things that they did care about. Right? But we've seen that in that project, not only did HIV new infection rates go down, but death from HIV went down, blood pressure control went up, and stigma for all these diseases across the community went down because they were linked and sort of normalized. On the how, the expansion of platforms and systems for serving people. We know fortunately or unfortunately, but I think fortunately, building on what Dr. Alenye mentioned, for HIV, there's never been able to be this acute versus chronic separation. When we're successful, it's both. We keep people alive and we help people have a healthy lifetime of treatment. And so systems that have been built to reach people, to put tools in the hands of the community, not just in the facility, to support adherence and lifelong sort of connection, those serve NCDs extremely well as well. And then I think the who has also come up today already. Our lessons from HIV will be community-led, community-led, community-led. The importance of services, governance, and accountability by people affected by a disease or a condition, for people affected by a disease or a condition. We have seen that deliver sustainability, creativity, agility in ways that continue to serve. And then I think finally we have a potential that we haven't always leveraged, which is the potential to join up movements. Sometimes we're all in our own movements, but we had this experience in Eswatini where a group of young women living with HIV got trained in cervical cancer and worked with cervical cancer support groups as well to really mobilize testing and destigmatization of cervical cancer as well. And in only 2 years, that's part of the model. In 8 sub-Saharan African countries, over 1 million women living with HIV have now been screened and treated for cervical cancer. And that was the power of joined up movements. And we need to think thoughtfully about more of that.
Thank you very much, Shannon. And I think both your very clear example of what happens if you offer some form of integrated care or prevention strategy and the joining up of movements, I think, are really messages of the day that we are learning so much about, and where the long-standing, sadly long-standing HIV/AIDS experience really teaches us. At the beginning, there was also a great optimism how quickly one will get a vaccine, and it never happened. So I think you can also bring some realism to the debate, but also some optimism, how one can live with a disease and how one can move forward. I'm moving on now to Dr. Jennifer Cohn, who's the Vice President Cardiovascular Health of the Resolve to Save Lives initiative. And that, as many of you know, is an initiative of Vital Strategies. And they have played a key role both in the COVID-19 response, but also, of course, in relation to NCDs. Could you share some of that experience with us from Resolve to Save Lives? And I think, again, you've tried particularly to focus on inequalities and how to address them. So Jennifer, please share some of that with us.
Great, thank you. And thanks to the organizers for the invite to this important discussion. So unfortunately, as all the other panelists have said, we now know that in many countries, the mounting excess morbidity and mortality is due at least as much, if not more, to restrictions on access to essential services, including for diagnosis and care of chronic diseases such as NCDs. And so reducing the mortality due to COVID-19 only to have deaths increase from other diseases such as NCDs is really a Pyrrhic victory. So the question is, moving forward, as you mentioned, what can we do to ensure this is really a turning point for action on NCDs? And at Resolve, we think that we can save 100 million lives globally over the next 30 years by increasing global control of hypertension from where it's at now, 14% to 50%, by reducing global dietary sodium intake by 30% and eliminating artificial trans fats in our food supply. And given the dangerous synergy between COVID-19 and NCDs, addressing these issues now may actually save even more lives. But fortunately, there's actually a lot we know about how to prevent and treat NCDs. There are proven interventions to prevent NCDs, and we can use the spotlight that COVID is shining on NCDs to advance policy change that will support lasting implementation of these successful prevention interventions. So for instance, to prevent a range of NCDs, we can work towards feasible, effective interventions, like passing legislation to reduce and eliminate tobacco use, as well as promote healthy foods by introducing effective front of package labeling for packaged foods and eliminating artificial trans fats in our food supply globally. We can also successfully reduce sodium through support for low sodium salts and condiments for home cooking, and policies and legislations that reduce sodium in packaged or institutionally prepared foods. Now, many of these interventions are actually best buys in public health, but in too many countries, the political will just simply hasn't been there to move these interventions forward. And now with COVID, this situation could really change. But we can also do much more to actually diagnose and treat NCDs once they've developed. So first, we think we must work to find simplified algorithms for NCD diagnosis and treatment to make sure that care is accessible and scalable. Now, in hypertension, the WHO's HEARTS package offers a great example of ways to simplify algorithms and develop and implement streamlined protocols for hypertension treatment that actually allow primary healthcare workers to initiate and appropriately adjust treatment and attain control. These simple treatment algorithms are actually now in use in 12 countries. Next, we have to make sure that community-based and person-centered as well as rational and sustainable care is developed from a healthcare system perspective. And we can actually learn a lot from another disease that Shannon just mentioned, HIV. HIV programs have used care models that support visit spacing, decentralization, and community-based diagnosis, treatment, and care. And these models actually support continuity of care despite clinic footfall and can support this continuity of care when services are disrupted. And COVID-19 is actually pushing us towards these models of care for people living with the NCDs. In India, China, and Ethiopia, they're attempting to provide continuity of hypertension care through support for multi-month refills, appointment spacing, and even community distribution of medications. Telemedicine is also being scaled up in India as a really important intervention that can allow for treatment modifications from a patient's home, moving care closer to the patient. And adapting these care models to other NCDs can actually help us maintain a life-saving and sustainable pathway of care to those with NCDs. And these models can help us scale rational and sustainable and affordable models of care into the future, even when there's not a global pandemic raging. Now, you also mentioned, of course, oops, sorry.
When you keep the next bit for the next question, please.
Of course.
That would be helpful. Then we have time for a second round. You're also motivated and have so much to share that I always hesitate to stop you because it's so interesting and exciting, and I'm sure our participants feel the very same way, but moderators have this task. I must say, as a moderator, I was very happy when I saw that the organizers had put on the agenda the whole situation of very disadvantaged people in camps and in extreme humanitarian situations, because sometimes that sort of falls out of the spectrum of the picture. And we have Dr. Kai van Habu with us, who is the head of the sub-office of the World Health Organization's Cox's Bazar in Bangladesh. And from him, we are hoping to get a bit of an understanding what actually happens in this kind of situation in a refugee camp. I mean, there's been so much talk, how can we even bring NCDs into these, the treatment of NCDs and the prevention of NCDs into these difficult situations. But what happens when COVID-19 is also on the scene? Can you share some of those things with us, please, Kai?
Thank you very much, Professor Ghebreyesus, for this question, and good evening, everybody from Bangladesh. Thank you also for the organizers to invite me to participate on this panel and to share our experience here from the field in Cox's Bazar. And also I would like to thank the government of Norway for the generous support to WHO in the response to the Rohingya crisis in general, as well as now in response to COVID-19 here in Cox's Bazar. Perhaps to give a very brief overview of the context here, as I'm sure you are all aware, we have more than 850,000 Rohingyas that are currently residing here in the district, which is one of the poorest parts of Bangladesh as well. They live in extremely congested camps, most of them since the major influx started, which was in August 2017. And I think it is fair to say, as Professor Ghebreyesus already mentioned, this is one of the most vulnerable and disadvantaged populations in the world. And due to past experiences, this population is also very skeptical towards authorities and organized services in general, which poses a particular challenge when providing health services, and even more so now in the COVID-19 response. In the past months, WHO and all the partners here on the ground have really worked tirelessly to prepare for the outbreak of COVID-19 in the camps, and we continue to do so. But also prior to the COVID pandemic, we have been very active and worked very hard to establish non-communicable disease diagnosis and treatment capacity inside the camps. And I think we have achieved some significant progress, and I would like to share some of these experiences with you. In 2019, we have established a dedicated team for NCDs here in the Cox's Bazar field office. And at that time, as you can imagine, there was very limited capacity on management of NCDs in the camps. This is also in part, and I think that also colleagues have alluded to that already, this is in part to the nature of humanitarian work. We have, of course, a high turnover of staff here. We have very many clinical staff who are very junior, which really, and of course, we have a very large number of partners responding to the crisis in the camps. All of this leads to a significant variability of the services that are offered, and at times, and in particular, in the absence of national protocols. This was the case in the beginning of the crisis, but WHO at the national levels, together with the government, supported the government in developing treatment protocols for main NCD NCDs, and that really helped as well to professionalize the response. But all these factors that I mentioned have really affected the continuity of care for NCD patients. And another aspect that I just want to mention is that we are still seeing a mindset, in particular among humanitarian responders, that have a strong focus on communicable disease response. Of course, this is a very important aspect, in particular in the camp setting. But that is not a reason to not also focus very strongly on non-communicable diseases. And I think a lot of progress has been made here, but there's still a long way to go. When we talk with partners about these issues, and when we have introduced this, in particular, our approach to NCDs, we have been asked by many, is this really a priority at the moment when we are looking at measles outbreaks? We have cholera cases in the camp. Now we have COVID-19 in the camp. But I think it's important, and that is already also what other partners have mentioned. Even in this context, it's extremely important to maintain essential health services, and in particular also NCDs. And that also includes the continued focus on prevention of NCDs, advocacy for diet, physical activity, etc. I think this is a very, very important aspect that needs to be maintained, and we are working very intensively with our community health working group on promotion on community health promotion and community mobilization to maintain the awareness about that. Just to say that, okay, thank you.
Next time round. So before we move into our second round, I had been very optimistic at the beginning that we will have 3 rounds. We won't, I can tell you that, because our speakers have said so much. But before we go to the next round, can I ask you again to just stretch a bit and get your mind working again and the blood flowing through? And maybe, you know, I can't as a moderator, but some of you can get up and just stretch your legs. We're moving on to our second round, and I would like to ask our speakers both to add some, you know, of the additional points that are important to them in terms of what is happening concretely, how the problem is being addressed, but also any recommendation they would like to see for the NCD movement to take forward in the context of the COVID-19 and the health security challenge. I can warn you, you have 3 minutes. I'm not going to, you know, sort of start with a timer or something, but do try and keep that time and leave us with a message that is really important for action. And that's also my request to the participants. Please do use the chat function, etc., to leave messages to the NCD Alliance and the other partners. What must we do? How do we take that forward? Who should we concentrate on? What kind of strategies have you used successfully? Because collecting those examples of success, we've heard some of them today already, will be absolutely critical. And we've heard some of them are relatively simple, relatively cheap. And if we only had the political will to do them, we could really move forward quite significantly. I'd like to call on Nupur again first. Nupur, we've heard so much. I'm waiting for her to come back in visually. Nupur, are you still there? Yes, wonderful. Nupur, we've heard so much about, you know, people's voice, civil society involvement, And Shannon also indicated, you know, bringing different movements and civil society organizations together. Can you also leave us with some messages on that? You know, how do we create that energy that addresses these problems jointly? Please, Nupur.
Sure, thank you. I mean, we're all aware that COVID has added a huge burden to the already existing issue of NCDs, and people living with NCDs are vulnerable as it is and at a risk for becoming, you know, ill or dying as well from COVID. So there are three points that I'd like to make here. One, of course, being build back better. You know, I think there is a huge need at this point to be able to build resilient nations, societies, networks of people living with NCDs, both locally as well as globally. And it's necessary to break silos and, you know, lived experiences of people like me. There are so many others like me. It makes us experts in a way, and people living with NCDs, I think it's very important for them to find their rightful spot at the decision-making table. It's very essential for them to have agency and, you know, not just be passive viewers, but also be developers and implementers of policies. I think people with NCDs, you know, need to move from simply passive participation to active collaboration and co-production. So I've been part of the of drafting the India advocacy agenda that was started by the Healthy India Alliance. And the India advocacy agenda basically emphasizes on the need to adopt a continuum of care approach, and to do this for NCD prevention and control. The advocacy agenda, it holds relevance while addressing the needs of people living with NCDs, especially during COVID, when importance needs to be given to not just prevention, but also palliative care, along with people-centered treatment and support. So this was the first point. The second point I want to, I spoke a little bit about it the first time I spoke, but I can't emphasize enough the power of, you know, the NCD community on mental health as well. So a lot of these conditions are viewed only from the lens of being a physical issue. But we've realized in the last few months since the pandemic has begun that the emphasis on mental health is very little or missing. There needs to be a strong network of people who can engage and interact with each other. And all of us are trying in our capacities to make sure this happens. The third point I want to talk about is the effective use of technology. For us living in developing countries, I mean, I'm from India, and even though I'm lucky enough to be living in a city and have access to telemedicine and have access to technology to consult with my healthcare providers and educators and dietitians, it's still a big challenge because there's a huge digital divide across the country as well. The divide is really stark because a few days ago I was interacting with a young adolescent girl from an interior part of India. She has access to internet, and she connected with me through the online helpline that we started. She's from a small state. She's from a state called Bihar in India, and it's amazing what technology can do to bring people together. Having said that, I also understand that there are certain limitations and that technology doesn't solve all problems. For example, alcoholism or tobacco, these issues still are probably untouched. But I think it makes a huge difference to be able to bring people together and, you know, sort of tie them with the same thread.
Thank you, Nupur. Thank you very much. I'm moving on to Sir George, and we've already indicated that it needs more investment, it needs more public spending. We also need to think money to a large extent, George. What kind of recommendations do you have there? How can one argue? We've done investment cases and all that kind of stuff. Do we need to change our argument? Please put on your, yeah.
You and I have been advocating for years how to get governments to behave in a better way. I'm going to suggest that if we want to get governments to behave more decently now and to link COVID and NCDs together, we have to emphasize the instrumental value in health. We have to say that COVID and NCDs reduce both the quantity and the quality of human capital. That is one argument we have to advocate firmly. NCDs and COVID reduce both the quantity and quality of human capital. We have seen NCDs impact negatively on COVID. What we sometimes forget, it was the same thing with SARS and the same thing with MERS. And the next pandemic, NCDs would impact negatively in terms of mortality. So briefly, what would I suggest? I'm going to suggest that we invest in the approach that is a life course approach, that we need to have as long a period of NCD life as possible to compress morbidity. And we need it also to reduce the possibility that NCDs contribute to mortality when the next pandemic comes. And I know John McCline, who's on the call, will be pleased to hear this. What we need to do is invest a lot more in children and adolescents, invest a lot more in preventing children and adolescents from developing the precursors of NCDs. I think it is almost criminally negligent to let children become fat. It's something that we can do. Governments can do this, stop children from becoming fat. So that is one comment I would make, one suggestion I'd make: invest progressively and more aggressively in the life course approach. The second is this: let us make common cause with those agencies which are advocating that governments spend more to develop their human capital at the country level, and induce those countries in their expenditure to improve human capital, they include control of NCDs. I would suggest those two approaches. One, to have us spend more on children and adolescents, stop them smoking, stop becoming fat. And two, make common cause with those agencies and organizations like the World Bank that are inducing countries to enhance their human capital and include the prevention of NCDs in that agenda.
Thank you, George, for that very concise and very clear message on investment that we should be taking forward. I'm moving forward to South Africa again, to Sandhya. And Sandhya, again, you know, it's a short period, 2-3 minutes. What are the key lessons that we can learn from South Africa, and how do you think this movement should go forward?
Thank you. Apologies, we've had load shedding and I'm struggling a little bit with the internet. Can you hear me?
Yes, very perfectly.
Okay, I apologize for that. I think the biggest lesson that we've learned and moving along the NCD agenda has been the learning lessons and leveraging lessons from the HIV and AIDS pandemic and how South Africa fought against that. But I think what we were presented with COVID was then witnessing absolute whole of government, whole of society approaches in play. And what we've realized that if this can be adopted for NCDs, then we will also be able to establish multi-sectoral action, which is then mandated and has the correct governance. And I think this is very important because with HIV and AIDS, their agenda was progress because a lot to do with the fact that firstly, they were receiving global funding, but they also had this mandated governance structure. So I think what we would like to see in South Africa is not to lose the opportunity presented by the establishment of these multisectoral structures, which start with the National Coronavirus Command Council, moving down to the joint command councils, which include all government departments, and then coming down to the National Department of Health. So the first thing that we can't afford to lose is the momentum achieved by this. The second thing I think we've realized is the enormous value of improving NCD surveillance. South Africa has really struggled with data. Not only as South Africa, I believe a lot of the neighboring countries have also struggled with NCD data. And what we've seen is in the provinces where they are using electronic patient records, we've been able to get much better data with regard to COVID and NCDs, for example. Integration at primary healthcare level is absolutely critical. This is not only for with regard to addressing HIV and TB and NCDs, and we are now seeing that if we lose the opportunity to address issues around COVID and NCDs at primary healthcare level, then we've lost a huge opportunity for establishing care pathways. And with regard to this, I'm going to be done. We've just, WHO has the WHOPEN. We have a tool called Adult Primary Care. And we've just finalized and approved a chapter which falls into this tool at primary healthcare, which is going to allow care pathways. And my last point is, I think our biggest challenge, and as a region, is going to be to address cost of diagnostics. We need to improve control of diabetes, for example. We need to reduce the cost of diagnostics related to HbA1c point of care testing. And we can only do this as a collective. Thank you.
Thank you very much, Sandhya, and thank you for that last point. As somebody on the board of FIND, the Foundation for Diagnostics, I very much appreciate that, and that's what we obviously advocate for. Shannon, we've heard so much, you know, we can learn so much from HIV/AIDS. You were also HIV/AIDS defined as a security issue at one stage. You advocated and pioneered many new structures. Sandhya has alluded to them. What are the 2-3 key messages you would leave with us in 2-3 minutes?
Well, I mean, I think what it is you can't underestimate the importance of a political moment, and you have to do the work to translate that political moment into ongoing dividends. It was really January 2000 where the UN Security Council just started debating HIV/AIDS as a global political agenda item because of security. That was actually transformational. I mean, to set the stage at that point, 26 million people were living with HIV, 2/3 of them in Africa. Treatment was not widely available. There were 9,000 new infections per day. I just had to go back and check that again, per day. You know, there were more people dying of AIDS than of the results of war or conflict. We had nearly 6 million AIDS orphans in Africa alone. And so it became really clear, especially if you're at community level, where this was disproportionately wiping out, you know, 25 to 45-year-olds, parents, you know, babies were being taken care of by grandparents. And it was clear that this was destabilizing not just families, but entire communities and entire societies. And so when the UN Security Council brought this up, that actually paved the way for the 2001 UNGA Special Session on AIDS, which was the first time in history that the UN General Assembly discussed a single health issue. And we made sure, the collective we, not me, the collective we, that came along with a 2001 declaration of goals that were time limited, that were member state accountable, and that led to worldwide reporting on targets, because it was set up that every 5 years we had to go back and report to the UN high-level sessions again. And each time we went back, we didn't just report, we said, oh, what's been missing? So in 2006, treatment targets were added because they weren't there before. In 2011, prevention targets were also added, as was a goal to eliminate HIV in children, as were resource targets. And then 2016, we realized some of the people being left behind had never been named. So key population members, men who have sex with men, sex workers, people who use drugs, prisoners were named in this UN declaration. And that has mattered every way along the stretch since then. You know, we had a panel at the last UNGA that NCD Alliance was on and Rollback Malaria was on. And the question was like, really, does this matter? Does this really matter? Isn't it just sort of a bureaucratic thing? And we had ministers of health that said, you know what? Every time there's a change of leadership, I get to go out and say like, no, these are the commitments we signed on to. It's not just me battling with another, you know, minister or secretary to get the limelight and the attention of senior people. We committed as a country. Same thing for fundraising, same thing for galvanizing attention. So I think that is a big lesson learned about not just how to act in the moment of political awareness and commitment that comes from, let's say now we're seeing health is wealth, right? These threats to economic security everywhere. But what are the steps then to hardwire that awareness into ongoing investments, ongoing dividends, and ongoing results for people? So that's what I hope.
Thank you, Shannon. Very, very clear, and an indication that what seems very tedious and difficult at times, you know, moving through all these UN channels actually does bring very concrete results at country level and is helpful for the people who are trying to make changes there. I think that's such an important message. We're moving on to Jennifer, and you were already sharing some experiences about, you know, what really helps us build back better. Are there any countries or examples you'd like to add to those you have already mentioned, you know, how we can really move a step forward in what's called the paradigm shift?
Great, thanks so much. Well, I think that there are countries, you know, Norway has been great in bringing forward the first country to really give NCDs its due, regional initiatives such as PAHO, and of course there are examples of great countries in each individual region, but I think it's too soon to really say this will be sustainable, this is a turning point. And so what I would say to kind of summarize some of the things I think we can do is focus, activate, and fund. We have to focus on high impact proven interventions, which means both policy interventions and clinical interventions for both prevention and treatment. We have to take the lessons learned from other diseases to simplify and bring care closer to home so it is actually sustainable and affordable from a health system perspective. But of course, then we have to take all these lessons and put them in front of decision makers, and we need to use this opportunity to activate the decision makers. We can take this opportunity to move commitments, to move those targets, treatment targets, regulatory targets, and importantly, budget targets from key decision makers and funders. And I would say that COVID, one of the questioners talked about COVID being NCDs being a silent killer. I would say COVID is actually giving voice to the silent killer that is NCDs. And it's time to change that narrative about how we speak about NCDs and how others speak about NCDs. The biggest killers of NCDs are not actually inevitable. They are preventable, treatable, and they are an emergency and an epidemic. And COVID has really also made it clear that we have to pay now or pay more later. So just like any other epidemic, the epidemic costs from NCDs will only grow if we don't activate these interventions to prevent and treat these diseases. And who will pay? It will be governments. It will not be industry who may be pushing back against some of the policies that we do want to pass. So I think that's a really important message that we also need to carry. And then finally, we have to fund and address costs. So budgets, we need to define what is needed, and then of course demand that this is what comes from donors, governments, and even think about innovative financing strategies. And we must use kind of the opportunity to get commitments now to ensure that there's transparency on these budgets so that we can hold decision makers to account. And finally, just to talk about that
sorry.
Sorry.
I have to give the word to Kai. Kai, will you leave us with a message in relation to the most vulnerable? What is it that we need to do in relation to NCDs and COVID-19. Give us 2-3 really striking arguments why investments are necessary there and how.
Thank you very much for the question. I think one of the main lessons learned from our response here with focusing on the most vulnerable is how essential risk communication is, and I think that also was clear from many of the colleagues. I think that is something that perhaps in the health humanitarian health response sector was not always put in the center of the response, but now it's really, we have realized how important it is to integrate community members in the decision making to make sure, because that is the only way to have the impact we want to see in our activities. We have to make sure we include the people's perceptions, the traditions and fears of the community members. I think that's something that we have learned on the global level and that we see here in the camps in particular as well. I think one opportunity that we have observed here is that among the general population, both the host as well as the refugee population, there's an increase in health consciousness. I think people have realized that NCDs have a major factor on the susceptibility to COVID-19. And I think this is something that we can build on. There is a greater interest in healthy living, even among the most vulnerable. And I think this is, as Jennifer and many others mentioned, this is a crisis, but it's also an opportunity, and we need to build on that. We need to increase the health awareness among the public, and we should also use that opportunity from among the decision makers and the donors, the greater awareness about NCD prevention at the moment, including, for example, this initiative from the Norwegian Ministry of Foreign Affairs, which we really appreciate very much here as well. Over.
Thank you very much, Kai, and thank you so much to all the contributors. It was such a wealth of information and examples and proposals, and I apologize profusely to those I had to cut off, but that's the hard task of the moderator, and I'm starting to learn how to do it virtually. You know, in real life, sometimes it's easier to get someone to stop talking, but it's just also a description and an indication also of your passion around these issues. And I think, you know, public health needs everything that you've said. It needs the data, it needs the agency, it needs the joining up. But in order also to grasp this political moment, as we heard from Shannon, and to stick with it, you know, it needs a heck of a lot of passion. And so I think those are really important things that not only you spoke about, but that you illustrated in how you spoke and the issues you put forward. I'm not going to summarize all this now. First of all, I don't have the time. And a second, I think it will be done in a variety of ways by the organizers to share with the wider world. I just want to raise 3 points that were mentioned a little bit on the side, but I think that will will need our attention as we move forward. We heard from one of the speakers, the impact of this is going to be with us for years to come. This is not a crisis that's going to stop tomorrow. And even if COVID-19 stopped tomorrow, the impact is going to be with us for years to come. The other, which we've of course heard for many other security issues and health issues, is this notion of, you know, it can be very destabilizing in society for specific groups, for specific areas, for specific generations, and sometimes even for society as a whole. And the third, and I think Sandhya mentioned that if it gets really bad, it means a crisis in democracy. and that, you know, there are political issues that come to the fore if we cannot manage public health issues, or if our health institutions fail, or if our leaders fail us in health. And those, I think, are issues. I think it was Jennifer who said, you know, how important the obesity issue is. George, who said, invest in your next generation and your young people. Otherwise, you really endanger your society and your democracy. And that's the message as a moderator I would like to leave with you. And I think I hand over on the dot, because I live in Switzerland, on the dot when I've been told at 15:35 to Bente Mikkelsen, who's the director of NCDs at WHO. Bente, over to you.
Thank you very much, Ilona, and thank you to an amazing partners, panels, and I think in a sense, and it's a horrible thing to say maybe, but in a sense, stars are coming together. And it's said in many ways that the voice of the silent killer has now been sort of amplified, and a spotlight is now on NCD, and the deadly interplay is there. And I would like to, I will not repeat any of the things that I've said before. I just want to sort of summarize with some of the asks that has coming out of the whole sort of process of realizing the facts during the pandemic. And I would like to say that actually it was because of civil society and healthcare workers that we realized that we had to really check how is the disruption in the healthcare system. We understood, but we didn't really feel it by our hearts. So as you know now, we need to do better. So I think the most important thing is to secure seats at the table for people living with NCDs, and not only living with NCDs, but also living with diabetes, with cardiovascular disease, respiratory diseases, and cancer. And also people who are young and old. The whole life course need to be represented, because there are big decisions that needs to be made for the next generation of NCD. We need to prevent the crisis, as many have said before, and it is amazing that even if we see that NCD is into the national preparedness and response plans, we are pretty sure that it's not to the extent that really will support and protect people, not now and not for the future. So we have to do better. We have to be much more clever in really integrating NCD into primary healthcare, and to cover NCD also by UHC benefit packages. I'm very happy to say that already this week we will have a strategic roundtable addressing exactly that. Existing domestic fiscal measures need to be in place. We cannot ignore anymore. And as many have said, this is not only by people living with NCD, but it's also the protection, the prevention. The comprehensive solution for people also require civil society engagement. And thank you very much to NCD Alliance for the Solidarity Fund. And thank you very much for Norway as the first OECD country that has really developed an NCD development strategy. This is very much needed. I think the last point from me, last 2 points, is that we need to not hide how many people actually are living with these diseases. We cannot just discuss it in a very overarching way. We have to discuss, and we have to show that even 5% now increase in people dying from diabetes. So it is the other way around than we wanted it to happen. We really want to see the decrease, but we see diabetes increasing in premature mortality. And the last thing, we must also learn from all the innovations. We heard some today. We saw that from the survey we did in WHO. There are many good examples, and digital health among them. But at the same time, when we have new solutions, we also have to be sure that this is solutions that create equity and not inequity. But a lot of innovation is going on, and let's learn for the future, and let's build back better for the next generation of NCD. So thank you very much. It's a pleasure to be in this meeting. Thank you. And
Thanks,
maybe
Bente,
Yeah, exactly. So Katie, please.
It's fine. I can pick up here. But thanks, Bente, and thanks to Ilona for, as always, the expert moderation and brilliant timekeeping. And also to our panelists for such a thought-provoking conversation, both on what the pandemic has taught us so far, but also what we need to be doing differently going forward to build back better. I guess just to complement Bente's kind of closing remarks, I'll just end with 3 takeaways that I took away from the conversation. First and foremost, I think if COVID-19 teaches us nothing else, it must be a wake-up call for governments and political leaders to really value, to prioritise and to invest in health, in NCDs and prevention, and early life prevention, as Sir George really quite rightly highlighted. I think the worst thing that could happen post-pandemic is that we see an austerity pandemic, and that we see governments leaving the public health tools and services to rust following COVID. Instead, we really need to make sure that we see long-term investments in resilience, in terms of health services, in terms of healthy societies, in terms of social protection systems, so that we're making sure that our vulnerable communities are well protected. Secondly, the second point I took away from the conversation was that the deadly collision of NCDs and COVID demonstrates the need that we need to bring these agendas together in terms of health emergencies, humanitarian responses, and the health security agenda. And to try and see these agendas as part and parcel of the same thing, rather than being vertical. Acute pandemics, chronic pandemics, with very similar measures and responses required. But in order to do that, I think we as an NCD community need to be breaking down the silos that we're all very comfortable in living with, because we know that people's experiences, as Sanjay highlighted, with multi-morbidity being very much a norm rather than an exception in South Africa, silos at the policy level are completely nonsensical for people living with these multiple conditions. So we need to make sure that our health services are responding in a way that treats people as a whole rather than as different parts. And also, I think this crisis has shown, as Shannon really rightly pointed out, that we need to be joining up our movements much better, and to be engaging in new political fora and with different actors across emergencies, pandemic preparedness, humanitarian sector, where for many, the messages of NCDs will be new. And knowledge and capacity may be quite weak, as Kai pointed out, within the context of the humanitarian responders. Thirdly, and my final message, takeaway message would be, I think what we've heard across the panel and from all of our speakers is the need to invest and engage in communities. I think Shannon said at one point, the lessons from HIV is to be community-led, community-led, community-led. The call to focus and engage the community should be taken up everywhere as both a public and a primary health service issue, not only to prevent and contain infection, but also to support communities, raise awareness, and support post-COVID recovery. And within this goal, our goal should really be about making lived experience the engine of our movement, as Nupur really highlighted, and push for the meaningful involvement of people living with NCDs. Too much we're still seeing tokenistic engagement at the country level and regional level. And obviously at the beginning, NCD Alliance's president launched our new Civil Society Solidarity Fund on NCDs and COVID, which we're really delighted and excited about. But I think it's important to say that this effort can't just come from civil society. It's really got to be seen and to be walking the talk by governments and multilaterals as well, if we're to see this become a reality on the ground. So I have the honour of closing the event, and just to really thank everyone again for joining us. I think at one point we had 400 people online, which is fantastic and surpasses everything we've been able to achieve through our events at the World Health Assembly, where this was originally planned to be held. So thanks again to our co-hosts, WHO and the Norwegian Ministry of Foreign Affairs for joining us for this. Thank you, Ilona, again for the expert moderation, and thank you for all of our panelists for your brilliant insights. And above all, thanks to everyone who's joined. As I said at the beginning, we've been collating all of your insights, your questions, your comments in the chat facility on Zoom, and we'll be using that to inform our advocacy going forward in this important area. So thank you, everyone, and have a good rest of your day. Goodbye.